Hello, everybody, and welcome to a new episode of Home of Medicine podcast in association with the Royal College of Physicians, Edinburgh. My name is Ben Lovell, and I am an acute medicine physician working in London. And here is my co-host.
Hi, I'm Amie Burbridge, a consultant in acute medicine and working at Lincoln Medical School, which I'll never get tired of saying.
You should never get tired of saying next. It's a wonderful achievement. So those who've been following the order will know that it's my turn to present a case to you today. And it's an SDEC case, same day emergency.
Okay. Oh, I like these ones.
I know you do. You like a bit of SDEC. So it's
I love
a 36-year-old lady, 36-year-old, referred in via GP for a same day emergency review with palpitations, intermittent palpitations. All right. And I'm going to say something now, and I want your reaction. She says, I've had them my whole life, but I've never seen a doctor about them. But I've just registered with a new GP, and he didn't like the sound of it, so he sent me in. Thoughts, please?
Okay. About the palpitations or about the referral to SDEC?
Anything you
both?
like.
Okay. My initial response is, seriously? She's had them all her life. Why has she come to hospital?
Mm-hmm.
I guess I want to know what the whole of life is. Does the whole of life mean adulthood, or does it mean childhood and adulthood? So I want some clarity around that as well. GPs don't normally send patients to hospital for no reason. So there must be something in the history that the GP felt a bit icky about and was like, I think this needs seeing. So
that's a very kind. I had the same reaction. Palpitations, whole life. GP wants the same day emergency review today. For real? Okay.
Really?
But that's fine. Sometimes we react without getting the full picture. So This is someone who has had palpitations their whole life, and she says, I do get them banging in my chest. Very annoying. It's just part of normal for me now. I've had them as long as I can remember. And I know exactly what triggers them. It's lack of sleep. And when I take big gulps of cold drinks, then I get them. And they can last for a few minutes or up to an hour. And I've just adapted to this now. I try to take small sips and warm fluids only. But I just flew back from the States, and I didn't get as much sleep. I was jet lagged, and there you go. I had a little bout of it, but they've gone now. And they're pounding on my chest. And that's about it, really. And I just wait them out. And then I've learned to ignore them over the 36 years. And I sort of push them to the back of my mind.
I mean, that's not normal to have to sip cold drinks because of the concern that this could lead to palpitations. So that does give me a bit, okay. You threw me in, I don't know if it's a red herring or something there, Ben, but you threw me in long flight. So I'm like, long flight, palpitations, PE. So I've got that in my head as I've all automatically gone, right, I need to make sure she doesn't have a PE. So I'm going to do 4 D-dimers hourly. No, I'm not really. Just to check whether the dimer increases over the... No, that's not true. I'm telling tales. So I want to think about acutely what could the concern be, and I'm going to want to rule out a PE. Any shortness of breath, any leg swelling, any risk factors for that. I'm also thinking, cold drinks, arrhythmia, Wolff Parkinson White, SVT, hypertrophic cardiomyopathy. Is there any family history? Or is it all normal?
So, so I'll answer your question. So, no leg swelling, no shortness of breath, and no chest pain.
Mm-hmm.
And past medical history was completely fine. Took no medications, no medical complaints.
Anything over the counter or the oral contraceptive pill?
Neither of the above.
Okay. I often find that people don't think the oral contraceptive pill is a medication. So I always ask about contraception separately. I think I've mentioned that before. Okay. Any family history?
No, nothing cardiac at all.
Nothing. Okay. Any thyroid abnormalities in the family?
Didn't ask, to be fully honest.
Okay. So I'm just now thinking of palpitations. What could the causes be? Hypothyroidism, cardiac, hormonal, life. That's terrible, isn't it? A terrible response, life. Do you know what? In this situation, I'm going to take a full history. I'm going to look at all of the different systems. I'm going to look at bowel habit, any diarrhea that would suggest hyperthyroidism. I'm going to look at the cardiac history, the respiratory history, any headaches. Yeah, I'm just going to do a full systemic inquiry. Yeah.
So everything was fine. This patient's quite bemused as to why she was there. And I think I said to her at one point, well, what do you need from me today? She was like, I don't know. I only came in because I was told to, but there's no real reason for me to be here today. This is something I've had my whole life, so I'm not quite sure what to tell you. But no change in bowel habit, I think you asked about. No other features of thyrotoxicosis. What else did you want to know? No signs of breathing abnormalities. No.
Any recreational drugs?
None.
Has she had any pregnancies?
No.
Okay. What type of work does she do?
She works in tech.
Okay.
I don't know what that means, but I gather she works sitting at computers.
Okay.
But I sort of glaze over a bit. I don't really know what work in tech means.
So you need to examine.
Okay.
Okay. What's her pulse like?
So pulse is 86 beats a minute and regular sinus.
Okay.
Her blood pressure is 131 over 81. Her saturations are 97% on air. Her respiratory rate is 16 and her temperature is 36.1.
All completely normal.
All normal. Yeah, but on examination of her chest is clear. There were no cardiac murmurs. There were no signs of heart failure or DVT. And I felt very clever, but I examined for a thyroid goiter and I couldn't feel any swellings on the neck at all because I had the same thought that you did about a hyperactive thyroid. And that's where we were, really. A woman sitting in front of me with a lifelong history of intermittent palpitations triggered by lack of sleep and gulping cold fluids, who was currently in sinus rhythm and completely well.
Okay. So you're happy that she hasn't got a PE?
Are you telling me or asking me?
I'm asking you. Oh, yeah. Was that something that you were thinking of? I don't know.
I really, really wasn't. Because you're right, a long flight, but on the background of pre-existing symptoms, it doesn't quite add up to me.
No.
I suppose people listening are screaming out, going, what was on the bleeding ECG?
Yeah, I know exactly. I'm waiting to ask you that.
The ECG was normal sinus rhythm. QT intervals normal, PR intervals normal, no bundle branch but morphology, completely normal ECG.
So I guess the question is, at this point, do you want to do any investigations in hospital?
Point. Exactly.
So are you going to do some tests there and then? Are you going to do some tests at the bedside? You're going to do a glucose. Obviously, we've done an ECG. And then are you going to do any blood tests?
It's a good question because we pretty much bleed everybody who comes.
I remember you saying that.
The nurse is standing next to me with a tray with a cannulation kit saying, what bloods would you like, doctor? And I'm going, I don't know if I want any because I haven't got a question in my head.
What about periods, alcohol, smoking?
I've written that down. Caffeine and alcohol intake I've written okay, i.e. fell well within normal limits, and a non-smoker.
Any menstrual problems?
Nope.
Oh, my gut instinct is to go, okay, do you know what? Let's watch and wait. But she's watched and waited for 36 years. So after 36 years and an admission to hospital to SDEC, should we now do some routine blood tests? And I literally detest their phrase of routine blood tests. But while she's here, should we check her hemoglobin, her thyroid function, potassium, calcium, magnesium, to make sure that they're all okay?
Okay, good question. I suppose let's think, what's our clinical question here? What could be the diagnosis?
Okay, so my clinical question is of these palpitations is, are these palpitations, number one, caused by a cardiac abnormality? So we've done an ECG, fantastic. Do I want to look at her sodium? If we've got a sodium channelopathy, which can rarely cause palpitations. Do I think this is an electrolyte abnormality? Do I need to check her magnesium and calcium? Does this lady have hyperthyroidism? Do I want to check a thyroid function test? Do you know, I would take bloods.
Okay, so I was umming and ahhing, and my clinical question was, has she got an undiagnosed paroxysmal arrhythmia? So
Yeah.
PAF or paroxysmal SVT.
Yeah.
That
Okay.
was now, I guess if I had to make a guess about a diagnosis, could that be it? Lifelong? Well, okay, you can be on Wolf Parkinson, right? Yeah, there are no delta waves in ECG, but you could have a lifelong structural or electrophysiological problem, which gives you intermittent palpitations. Intermittent palpitations triggered by drinking cold fluids. I was not, but you know what? I made my peace with that, and I said, okay. Theory that hypothesis I'm testing is, has she got paroxysmal atrial fibrillation or supraventricular tachycardia? So in that question, I think bloods are reasonable to make sure profoundly anemic or profoundly hyperthyroid. So I did do bloods as well. And that's how I rationalized it to myself. So I was answering a question, a clinical question. I was working up a clinical hypothesis. Does that make sense?
It does. I guess what you're managing here is uncertainty. And you're uncertain about lots of things. You're uncertain about whether she should have come to hospital anyway in the first place. You're uncertain about what the cause of the palpitations. And I guess you're uncertain about, is this something I even need to be worried about?
Yes. And I think that's a relevant question, because SDEC, same day emergency care, we're under the auspices of emergency care. The clue's in the name. And should this patient just be in her GP surgery? And I don't say just the GP surgery to belittle GPs, but is primary care not a better place to be working up a lifelong problem? But the fact was, we're here now, and I'm the doctor standing in front of her, and it's and there's a nurse standing there saying, what blood test do you want? So there we go. So I did do those bloods, I confess. Anyway, didn't get me any further forward. All her bloods are normal. Thyroid function normal, FBC, USINE, CRP, all completely normal.
Did you check LHF and FSH?
No, why?
The only reason I'm saying that is I know she's 36, but menopause, perimenopause,
lifelong palpitations.
Okay, fair point. All right, okay, that's a silly question. I'm trying to. The thing is, now I'm biased because you're talking about this case on the podcast. I'm like, there must be something wrong.
And we've had this conversation before. The fact we brought this case to the podcast, there's a sting in the tail somewhere. Surely that's not the end of the story. She went home and they all lived happily ever after.
Yeah.
Episode.
Maybe we have just discovered a new bias.
Podcast bias.
Mm-hmm. Yeah. Homeless medicine podcast bias. Yeah.
No, we'd have to call it after us. The Lovell Burbridge bias.
The Burbridge Lovell bias.
Maybe alphabetical. Okay.
Only joking. Okay, so we digress. So at the moment,
what next?
So I'm going to do a problem representation of this patient then, because I find that helps. So when I'm not entirely sure what is going on, I like to go back to basics. I have a 36-year-old female who presented to her GP with lifelong palpitations. There are no associated symptoms. However, the palpitations are triggered by lack of sleep and cold drinks. There is no history of recreational drugs, a high alcohol intake, or caffeine or smoking. She works in quite a sedentary job. No family history of note. Examination is normal. Observations are normal. ECG is normal. Blood tests are normal.
The only asterisk I would add to that is ECG while she wasn't having symptoms were normal. Yeah.
Good point. So I always ask myself this question: does this patient need to be admitted to hospital? No. Patient can go home. Do they need follow-up? Do they need further tests as an outpatient? Am I going to do a 48 to 72 hour Holter monitor on this patient? No. Yes. No. Yes.
Goodness me.
And as I'm saying no and yes, your eyes are going up and down. And do you know what? In clinical practice, no, I wouldn't. I wouldn't do a Holter monitor on this patient.
Fine.
Whether that's right or wrong. And I'm sure there are lots of other people who would.
Yeah. I think if you do a Holter monitor, that you're then committing your service to follow up results, because we always follow up results of tests we organize. You can't say Holter results back to GP. That's not how it works. So do you want to take that on as your SDEC team to arrange a Holter? I don't know what your Holter turnaround times are. Ours are many weeks, if not months. And then follow up the results of that, and then, act upon it. And a 24-hour Holter, 72 a week, those are the sort of decisions that you're making. And I found a bit of a halfway house for her. I mean, this was a very intelligent woman who'd been living with symptoms for long and was a bit perplexed as to why the doctors were so interested. I said to her, she volunteered to me, my dad has that Apple Watch thingy with the cardia attachment on to monitor his heart rate.
Great idea.
Can I just use that when the next time I get symptoms? Because I will get them, or I'll even go home and have a big cold drink and trigger them, and then I'll do it, and then we'll know what's what.
That's a fantastic idea.
And I said, you know what, let's do that. I trust you to do that. And I thought that would be the last I ever saw of her. End of the episode. No, just joking. And I sent her home very pleased with myself. And 4 days later, she rang our 7-day safety net service we have in our SDEC. It's a little phone number you can ring any morning if you were a recent SDEC patient, if you're not right. And she rang it and said, oh, something happened. My dad's cardia thingy says I've got something that I need to show to a doctor. So I said, please do come in. I said, how do you feel? She went, I feel fine. I had a burst of symptoms, did the thing on the Apple Watch, and this is what it's telling. And she came in and she showed me this strip as a screenshot on her phone, because she'd taken a picture of her dad's watch, so a bit blurry. And it's a screenshot of a one lead ECG trace, as you get from these little devices, a bit out of focus, but showing atrial fibrillation. But it had her dad's name on it. So it said something, let's say it said Bob Smith, atrial fibrillation. Yeah, but that's my dad's name because it's registered to him. But that was my finger on the button, and it was me, honestly. And that was when I went home and I went to my dad's house and I had a big drink of cold water and triggered the symptoms, and then I put my finger on, and there you go. So Bob Smith, whoever has now got AF somewhere out there, but is Bob Smith my patient? She says it is. Did an ECG. She's back in normal sinus rhythm again. Where do we go from here?
Do you know what? I'm going to speak to the cardiology reg on call and get some advice. Actually, I need it for it. Well, because podcast bias. What I'm going to do is, so we've got a couple of options. Number one, does she have any transient loss of consciousness when this happens?
Okay, good question. So now we're wondering about, does she have any signs of unstable tachycardia? So you're asking about syncope. No, she doesn't. The other three signs of instability would be chest pain. She was negative for chest pain, heart failure, and shock, i.e. hemodynamic compromise. And admittedly, we've never done a blood pressure in the moment, but she never felt pre-syncopal or unwell. It was annoying.
So I guess what you're looking at on the tracing is paroxysmal atrial fibrillation, which has inherent risks associated with that. So number one, I could do a Holter monitor, aware that it could take a long time.
Yeah.
Number two, an implantable cardiac device is a potential. Number three, have a chat to the cardiology team and get some advice. Number four, get her to get her own watch with her own name on it and to keep an eye on this.
Well, they're expensive. You're going to go and tell her?
No, maybe not. They are expensive, aren't they? Would you admit for observation to put on a monitor and to drink cold water in hospital or in SDEC to try and activate it so you actually see it when it happens?
I did think about that. Think about going to the water cooler.
Yes, that's what I was thinking. You know, should
this?
Yeah.
I just wasn't really on board with that.
No, I know.
Whole correlation.
I understand.
Yeah, I just didn't know if I wanted to go down that road.
What happened?
Well, but I want to push you to a commitment.
Okay. You want me to know what my plan is?
Yeah.
So I'm already imagining if I speak to maybe the cardiology team, they might say admit for observation.
Okay.
Or some people might say Holter monitor, but aware that could take a very long period of time. I could speak to the cardiophysiology department and say, is there any chance you could fit one today?
And when they'd finished laughing at you down the phone, then what was your next option be?
Okay, I'm going to do an outpatient 48 to 7. I'm going to do an outpatient 72-hour Holter monitor.
Mm-hmm. Okay, great. And then just follow up the results as and when they're available, and safety the patient, and say,
absolutely,
whilst the Holter's on, if you fancied a big cold drink, then you go for it, as long as that's safe, and we'll see what happens.
But also saying, as you've got your dad's watch, if this happens, maybe try and record the tracing. And again, any concerns, maybe email me the tracing, or pop into your GP.
Do you give patients your email address?
I've never done that, Ben. I don't know why that thought has never come to me before. I don't know why I said it.
Not in a profession where we see hundreds of patients.
No, I think it'd be very difficult, wouldn't it? Yeah.
All right then. So the conversation I had with myself was, I've got some evidence that this woman is in PAF. I've got a dodgy screenshot of an ECG recording with the wrong patient's name on it, but she's telling me that's her recording. Do I have enough evidence to start treating her? And if so, with what? First of all, AF, this is our bread and butter in acute medicine, rate control, anticoagulation. So do I offer her a low dose beta blocker just to maintain sinus rhythm moving forward, like 1.25 with bisoprolol? Or do I offer, and I thought about that and I thought, no, because I don't think medical legally I have enough evidence to say I diagnosed PAF in this patient yet. Doing this anticoagulator to prevent her from having a stroke. She's had it for her whole life. That doesn't mean you don't anticoagulate someone with known PAF. What's her CHA2DS2-VASc score? Her CHA2DS2-VASc score comes out at 1 for being female, and the CHA2DS2-VASc score says you don't need to offer anticoagulation. That 1 point is just for gender. That's okay. That's a relief. So I don't have to. If she was 76 rather than 36, then I'd be thinking, maybe I should be trying to pin this down, because she could have a catastrophic stroke. So I said exactly what you did. I said, let's do a Holter and let's just see what's what. If this is something that can happen with you lifelong, I think we can afford a few more weeks. And I requested a 72-hour Holter, which is what you said. And I said,
did you do 72 hours as well?
Yep. And I said, if you can trigger these whilst the monitor's on, that might be really useful information for us to have.
Did you do an echo?
Oh, that's a good question. I thought about an echo because AF in a young patient, you look for causes. At that point, again, I didn't feel I had enough evidence to prove that my patient had PAF. At least nothing that would look like it would make sense to a second reviewer, years down the line. All I had was that screenshot. I guess you could say, would you offer a young person with palpitations, even with normal sinus rhythm, an echo to look for structural heart disease? Yeah, could. I chose not to.
Okay.
So I booked her the Holter. I sent her home. She was happy with that plan. She's like, this is a lot of fuss about something that's my normal. And I booked her into our results clinic, which is run by a registrar, and they chase results of longer time wait investigations like Holters and outpatient echoes. And I thought that was the last I'd ever see of her. Chapter 3.
Yeah.
So eventually, her Holter monitor came back, and it was the most beautiful diagnosis of intermittent paroxysms of atrial fibrillation, fast AF. that completely correlated with the patient's diary, which symptomatically, she'd had a diary, and every time she had symptoms, she wrote it down. And she even very helpfully wrote things like large cold drink here, followed by palpitations, which matched up perfectly with her symptoms. This is a
Wow.
who had lifelong PAF. And I rang
Wow.
her. I rang her and I said, "We've got your diagnosis. You have something called paroxysmal atrial fibrillation. You probably had it for years, and we actually managed to nail down the diagnosis. And what we need to do now is refer you to a cardiac an electrophysiologist, a cardiologist with an interest in EP, and they will be able to discuss options for you, such as ablations and things like that." She said, "No, thank you." She said,
Oh.
"I've done some reading about that. To do cardiac ablations, they have to scar your heart, and I don't quite fancy that. And the risks, I'll just avoid cold drinks and I'll be fine." And moving forward. And I sort of went, "Can we stop with the cold drinks thing? Because it's just nothing I've ever picked up in a medical textbook." And I said, "Look, with a bit of niggling from me, do you mind just going to meet the cardiologist? I'll make an outpatient appointment, and you don't have to do anything you don't want to do. All they'll do is suggest treatment options, but you've got to hear the crowd so you can understand all the risks and benefits rather than, chat GPT or Google it or something." She agreed to a referral. I did a referral. And I did some little research. I was like, what is this gulping cold fluid thing? And I found this actually, there are multiple case reports of patients who can induce a paroxysmal atrial fibrillation by gulping large boluses of food or water, or by having very cold drinks.
Wow.
And it was summarized in a study in 2019 where they interviewed patients and said, "What are your triggers, the most common triggers for your paroxysmal AF?" And they listed them. Now, what do you think is the most common trigger identified by patients to bring on a bout of AF?
Alcohol?
Alcohol, number one, 35% of patients. Number two?
Physical activity?
That's number three. Number two
Oh,
is caffeine, 28%.
okay.
23% said intense exercise.
Yeah.
21% said lack of sleep, which was relevant in my case.
Yeah.
10% of patients identified large meals. And
Okay.
7.5% of patients cold drinks.
Wow.
And there's a theory that it's some kind of vaguely mediated response due to the coldness, or or a very large bolus of food or fluid going down the esophagus can cause activation of the vagus nerve, and that increases parasympathetic tone, which can bring about or can lower your threshold for going into atrial fibrillation. She was talking a lot of sense, and she actually had managed to make it work by avoiding cold drinks.
Wow.
Isn't that interesting? I
It's
never heard of that
really
before.
interesting. So when she saw the cardiologist, what was the plan going forward?
She hasn't seen them yet.
Okay,
Yeah,
fair enough.
still waiting for that first face-to-face.
Yeah. It brings into a lot of thinking about shared decision making as well, doesn't it? There as well, like the patient really doesn't want treatment, but we're like, you need to have treatment. So at what point do you? Yeah, it's wow. Do you know what? Do you know what that tells us beautifully, Ben? Listen to your patient. They are telling you the diagnosis.
I thought it was a lovely case, and I really enjoyed talking to her. She was a fun lady, and I learned something from that, which I thought was really useful. Did you? Was it a good one? Did you like that?
I loved it, and I kept thinking, "There's got to be something. There's got to be something in this." Yeah, I've not heard of PAF lasting that long. It's not something we see very often in younger people, is it?
Well, she definitely needs an echo now, doesn't she? Now we've confirmed the diagnosis to look for structural heart problems, and that's something that's in the pipeline as well.
Wow.
So, and on that happy note, I'll bring us to the close of that episode. I hope you enjoyed guessing along at home, and maybe you can keep that little nugget in your back pocket. So when you're talking to your patients with PAF, you can ask them, "Cold drinks ever happened to you?" And they'll look at you and go, "Gosh, how did you know that?" And then you look very wise indeed. But thank you so much for listening, everybody.
Thank you.
We do ask, if you enjoy, if you could rate or review us on wherever you're listening to this podcast, because that grows our listeners and it means we can reach more people. And we love it when we get some feedback as well. So please don't be shy about dropping us a message, because we always respond. Thank you, Amie, for playing along.
Thank you very much, Ben. Thanks for listening.
Bye.
Bye.